Welcome to session number 44. My name is Anafi Mataka from ASLM, and I'm delighted to be your host today. This is session 44 of our series on COVID-19. It's a series that we have dedicated mostly to diagnostics in the pandemic. And today we have an interesting and a very important topic that we are going to be showcasing today. And it's on using digital tools to strengthen COVID-19 diagnosis and case management. As we have seen in healthcare in general, digital tools have that ability, or digital innovations most of the time improve our diagnosis and management of various diseases. This will be a slightly longer session than you are used to. We will have an hour and 30 minutes. We will have a couple of presentations, which will be interrupted here and there by Q&A. Please keep your questions and comments coming through into the chat box as the session progresses. A kind reminder that we also have simultaneous French language interpretation. Please feel free to choose the language of your choice. If you're using a desktop, you would find it right at the bottom right of your screen where you have the sign of a globe. You need to click that one on and you'll be able to choose either English or French. So to kickstart our rich lineup today, we have called upon presenters from mostly from FIND, as well as from Ministry of Health across a few countries, namely Nigeria, Rwanda, and India. And I would like to call upon our first two speakers to get us going, namely Rigveda Kadam. Rigveda is the head of digital access at FIND. She leads FIND's digital health work across the organization, including activities being undertaken as part of the FIND's role in the ACTA diagnostic pillar. Paula Akuzigwe leads FIND's country-facing work on the use of digital tools in the COVID-19 response, including the operational research and compilation of the series of case studies that you get a chance to hear today. Colleagues, allow me to call upon Rigveda and Paula to get us going. Over to you, ladies.
Thank you, Anafi. Just to quickly check, can you hear me?
Yes.
Yes.
Okay, great. So I'll not take much of your time. Thank you to all those who have joined us, and to our Muslim colleagues, wish you all a very happy Eid Mubarak. On the session for today, we have several case studies that we would be asking our partners from different countries to share their insights on. So we'll cover a brief introduction on how digital tools have generally been used in the COVID-19 response, and what was the context around how and why we went about developing these case studies. We would then hand over to representatives from the different countries to share their experiences on how they have used digital tools for COVID-19 diagnosis and case management, and what has worked and what hasn't worked, followed by some summary reflections on the key success factors. As you can notice on the slide, we'll have two opportunities for an interactive Q&A. The first one would be right after the presentation from India, and then the second one would be towards the end of the session. Paula, if we could move to the next slide. So the context for why we looked into the use of digital tools for COVID-19 response stems from the role that FIND is playing as co-convener of the diagnostics pillar of the ACT Accelerator. For those of you who may not be familiar with this, the ACT Accelerator was set up under the guidance of WHO last year to coordinate a global response across a number of pillars, diagnostics, therapeutics, etc. for COVID-19. Specifically for digital health, our focus has been how can we work with country partners to generate evidence on how digital tools can be used to strengthen COVID-19 diagnosis, and what can be done, and what are the challenges that need to be addressed. And then the second part of our work focuses on supporting the design and implementation of open access digital tools that can facilitate decentralized testing. To summarize the current landscape of the digital tools in the COVID-19 response at a global level, primarily at this point, most of the countries are using some form of digital tools, and these are across four different categories, primarily around surveillance, around prevention, around diagnosis and delivery of care. Towards the end of this presentation, if we have time, we've also listed a few repositories where interested partners and participants can take a look at what are some of the digital tools that have already been adopted and scaled globally, and what use cases from these four are covered. And we would also be happy to have conversations and interactions with any interested participants. There would be contact details shared at the end of the presentation as well. And thank you all for this opportunity. I'll pass on now to my colleague, Paula.
Thank you, Rigveda. And thank you all for being here with us today, and to ASLM for hosting this important conversation. As Rigveda mentioned, part of FINE's work focuses on evidence generation in various areas, including around the use of digital tools for COVID-19. And who better to provide that evidence than the people who are directly implementing these tools on the ground. And so the objective with these case studies was to promote that not just evidence generation, but also exchange of knowledge between countries to highlight learnings and tools that may be useful for other countries who are looking to strengthen their digital systems. This really represents, the case studies represent the immense work that has been done by the ministries of health or the implementing agencies in these different countries. FINE's role was really just to try and collate that information and help to write it up, but the inputs came primarily from interviews and questionnaires that were done with our MOH partners. And we would also like to take this moment to really acknowledge and appreciate their inputs over the past few months. It's not easy to create time to document a response while you're in the middle of implementing it with such urgency, especially given that all three countries have, in the course of the past few months, at different time points, faced second and larger waves of the pandemic. So we appreciate your inputs and we appreciate you being here today. The case studies are not an exhaustive overview of all the digital initiatives being used for COVID-19 in the countries. We couldn't, for example, also interview end users of the products. There's some smaller scale initiatives being used, digital tools being used. But what we really want to do is provide a perspective from the ministries of health that have managed to create very robust and well-structured digital and data science systems. The fuller case studies are available on FINE's website. We'll share that link at the end of this session. But for the period of this webinar, what each country representative will be sharing is just an overview of the approach, the specific operational considerations that went into implementing the systems, as well as the key lessons learned, successes, and challenges. So with that said, I'm very happy to hand over to Dr. Lois Olajide, who's a medical doctor at the Nigeria Center for Disease Control, or NCDC. Lois, in addition to her broader work, also coordinates the digital surveillance, outbreak response management and analysis system, also known as SORMAS, which is being used by NCDC for the COVID-19 response, both for patient management as well as epidemiological management and surveillance. And so over to you, Lois.
Thank you very much, Paula. Once again, my name is Lois, and I'll be taking us through our experience with the use of SORMAS in the control of COVID-19 in Nigeria. And so this system, surveillance, outbreak response management and analysis system, it actually predates the existence of COVID, as we have been using it even before we reported the first case of COVID-19 in Nigeria. And then it integrates both real-time surveillance as well as case management functions. Now, this system was conceptualized and developed following the issues, data quality challenges, and challenges with feedback mechanism that were involved during the Ebola outbreak. And since then, since the development of the system, it has since been used in the response to various outbreaks like Lassa, CSM, cerebrospinal meningitis, among others. Next slide. Next, okay. So some of the key features of this SORMAS is the fact that it is accessible by healthcare workers at all levels of care, the community, the local government, the state, as well as the national, via the use of tablets and laptops and their phones. And then it captures the geocoded data across the test, trace, isolate cascade, right from the moment an individual is identified as a suspect case throughout to the final case outcome. It also functions as a process management tool that automatically prompts the next step in the cascade in order to make sure that case management is standardized and efficient with built-in feedback mechanism. It's open source and it has been adapted to other settings and countries like Ghana. It's also being used in Fiji at the moment. And it also allows for a module-based approach such that there can be rapid addition of new data fields and case management functions. And this was made use of during the COVID outbreak, when even before we reported the first case of COVID-19 in Nigeria, the COVID module had actually been added to the system. Next slide. So there have been several tools that have been developed. So we have additional patient-facing tools which have been introduced, and these were introduced to facilitate public engagement, screening, and entry into the cascade of care. And all these, as we have on the right side of this slide, they all feed into eventually into SORMAS. We have our WhatsApp bot, we have our USSD SMS solutions, we have the chat box, and we have the Wellbees. So all these additional tools have been used in the response to COVID-19, and eventually they all feed into the SORMAS system. Next slide. So at the end, when all the data have been collected right from the lower level, right from the subnational level, the aggregate data that is generated from across all these levels, they are all used for surveillance and epidemiological analysis. And at the end of the day, they are available via the NCDC website. Next slide. So we had some practical steps were taken to scale up this system for COVID-19 in the response to COVID-19. And even before the COVID-19 pandemic, SORMAS had actually been deployed in 19 states. However, there was a need for rapid scale up in the remaining states to ensure that there is real-time data reporting, or as close to real-time as much as possible, and to ensure that our response is actually data-driven. So there was a need to rapidly scale up to all the 36 states and including the FCT, even before the COVID-19 pandemic, as well as during this COVID pandemic. And also, there was deployment of additional personnel to support the subnational level in the digital implementation and in the data management. We've also collaborated with partners who have facilitated the development of the different screening tools who eventually feed into the SORMAS system, as earlier mentioned. And the system is also interoperable with other systems, especially DHIS2 via a third-party tool, which facilitates exchange of data between or among these different systems. Next slide. So what are some of the key learnings from our experience in the use of SORMAS for COVID-19 response? And this will be the last slide. And so some of our strong success factors is the fact that we have strong national ownership. And this has been a characteristic of SORMAS right from inception, due to the NCDC's central role in the development of this system. And then the fact that we made use of inclusive design process, especially from our users, the potential users at that time, and the system has actually been upgraded from our users based on the feedbacks that we got from them. So we've made use of this inclusive design process, and then the investment of the domestic financing into the system. Before now, the SORMAS development and design was actually practically sponsored and funded by partners. However, with the use of, with being seen that this system is actually quite effective and useful, and because of this ownership that the Nigerian government wanted to take, so there's been a lot of domestic financing into the system, and also the consolidating of all data across the TKI cascade into one platform. It has enabled a deeper understanding of the epidemic in terms of the symptom distribution among the confirmed cases, and which has enabled us to have a more streamlined response. What are some of our operational challenges? So some of these include, one of them is the fact that there has been inadequate human resource capacity, especially at the subnational level, and this can result into delays in data entry into SORMAS, therefore negating the benefit of the real-time data capturing. However, there's been a development of the electronic CIF, and so with this development of the electronic CIF, which has been made public, this challenge is being minimized. And also with, every day there is a technological advancement. And so with technological advancement, some of the devices that had been previously deployed, there may actually be a need to replace them, as they may not be able to optimally support the SORMAS system. Thank you, and I will hand over to my colleague from India.
Thank you very much. Thank you very much, Lois, for that. And one of the common challenges that often comes up with the use of digital tools in emergency responses is just fragmentation of data across different systems. And so it's very interesting to learn about this uniquely comprehensive system that's used at all levels of epidemic management in Nigeria. I'm pleased now to call on our colleagues from India, brief introductions. Shuli, I'm not sure, can you confirm if we have the PSA present?
Yes, he's here.
Great, thank you very much for joining us, sir. We're very happy to have Prof. K. Vijayaraghavan, who is the Principal Scientific Advisor to the Government of India. So in this role, he chairs the Prime Minister's Advisory Council on Science, Technology and Innovation, which spans multiple government ministries and sectors, and he oversees national strategy on research and development, among many other things. He's a geneticist, a developmental biologist, so he really brings a wealth of expertise and experience to this conversation, and will also provide us with some more current context as the case studies were completed earlier in the year. So he'll be able to provide us with more current context on how they're being used presently in the response in India. He will then hand over to Dr. Lalitesh Khatragada, who co-created Arogya Setu application in India, which has been one of the most vital tools in the response, and has been supporting targeted testing for COVID-19. Dr. Lalitesh is a pioneer in crowdsourcing. He created Google Map Maker, which quadrupled the world's digital maps corpus. He has a PhD in robotics and computer science and builds various population scale crowdsourcing platforms. So we're really happy to have their presence today for this presentation, and I'll hand over to you now, Prof. Vijayaraghavan.
Thank you very, very much. It's an honor to be here. As we all know, these are very difficult and trying times for the world, and particularly so for India. We're going through a very tough period, and everything we do, whether it is digital or practical or on the ground now, is geared towards mitigating the suffering and going forward to ensure that our resources are structured in a manner that we can deal with what happens. My colleague, Dr. Lalitesh Khatragada, is actually fully and uniquely placed to address the specific topics on digital tools and data science. He's been incredibly involved, leading a team of people, both in development of the Arogya Setu app and in terms of developing and implementing the vaccination portal right now. So I will not get into what he will tell you best, but let me just give you very briefly the importance of digital tools in our context. Digital tools are a very important prosthetic in adding on to classical tools in every possible way. And there are two important kinds of classical tools which we need to address and see how digitally they can be used to scale. The first one is testing, tracing, and isolation. The standard way for doing that for many diseases for decades, indeed centuries, is to identify people with symptoms, isolate them, and also see if isolating those who they have been in contact with is helpful. Now this, first of all, works really extremely well in systems where symptoms are sufficient to identify people and who they have been in contact with, and where diseases spread slowly. And therefore this has great value and has great structure in all our healthcare systems all over the world. So that's very important. However, when two things happen, when epidemics or pandemics occur, and when asymptomatic transmission is critical, then we run into a big problem. The asymptomatic transmission of SARS-CoV-2 became apparent early on, but it was first clouded in a statement about the nature of this transmission. The early view was that symptomatic transmission takes place and that there was something called pre-symptomatic people who also transmitted, but asymptomatic people did not. And this is something which was quite a puzzle. What is the difference between asymptomatic and pre-symptomatic? That distinction went away as soon as it became clear that asymptomatic people transmit. The second point which came about, which took some time from the spread of the disease, how it's transmitted. The early view was that substantially that transmission was by droplets and by, from surfaces, and not by the flow of aerosols in plumes of air. This view also started changing steadily. All of these have important aspects for contact tracing, because it is not that everyone who's positive is equal. It is that there are both people and events which are super spreader events because of the way plumes travel and the way people speak. Now, all this needs to come in to a digital contact tracing mechanism so that very speedily people who are positive and their previous contacts for a certain number of days can be identified, all isolated, and a way by which they can know whether they are near others or not, and then isolate themselves. So this is the heart of the contact tracing mechanisms, the structures of which Lalitesh will tell you very well. Now, this kind of a structure where people identify themselves on a phone, where their data is secure, but it's uploaded at a time only when they are positive with their consent, is something which allows at the back end to create a large structure which can look at this in relationship to disease spread. It can also add on to this structure, which is largely through smartphones, other data which comes in from feature phone or other kinds of semi-smartphone data coming in when people get tested and give their phone records and their location. This backend is another very important component called Arogya Setu Itihas. Teams of people sit together and analyze this data every day and give advice right down to every level of healthcare at the lowest level about what is likely to happen, what kind of resources, therefore, that they might need can be planned for. Now, going forward, there are many, many challenges which are being addressed in terms of this huge spread. We now need to integrate testing on a much, much larger scale into this digital platform. Currently, substantially, the kinds of testing which were done involved RT-PCR-based testing, which were done relatively rapidly, but now with the huge surge going on, it becomes time-consuming and difficult to do access for everyone. As the pandemic spreads to smaller towns and rural areas, testing is going to be a bigger challenge. Testing is also going to be a challenge in terms of integrating that into digital information. These are the challenges which now need to be addressed and are being addressed. Different kinds of tests need to be used on a large scale. Rapid antigen tests, which had concerns about sensitivity in low prevalence situations, those concerns go away when prevalence is high. And they're very, very valuable in allowing people to frequently test and isolate themselves. ACTE and FIND have done good work on that area, and integrating that into the digital services is important. The final aspect of integrating into digital aspects in a large country involves vaccination. How do we know that everyone who needs to be vaccinated is vaccinated? Link them with the availability of vaccines, get them registered, tell them when their second doses, and get it done. This is a big challenge because, again, there are 3 levels of people in terms of access to resources: those who have smartphones, those who have feature phones, and in this category I include a third category, people who have access to the internet, and then there are others who don't have access to all of this. So bridging mechanisms by which those who don't have access can be onboarded in a large rush needs to be done. All of this is compounded. The digital experience is as good as the mechanisms by which it can be linked into implementation. Currently, those implementations for testing and tracking need to be scaled up and are happening. But in terms of vaccines, the key issue is about supplies. With a big surge, supplies, the demand has surged very rapidly, where supplies will have a certain lag over the next couple of months. In that situation, again, the integration of digital mechanisms, letting people know when supplies are available, is a big challenge, again, which the COVID team, which is involved in vaccination, is doing. With that, I'd like to hand over to Lalitesh for his comments and interventions. Thank you very much.
Thank you, Professor Vijay Raghavan. I'll just quickly outline the technical solutions we used. Some of them are similar to what Nigeria mentioned, so I won't elaborate on that. We did have an app called Arogya Setu, which integrated all the citizen-facing technical solutions into one. Arogya Setu stands for Bridge of Health or Health Bridge.
Just a reminder to go a little bit slower.
Yes, thank you. And what Arogya Setu did and does is that it has 3 interventions. One is it has a self-reporting tool using which a citizen can report if they are having any symptoms, and they can further ask for help if they are in distress. And India is a country where health is a state subject, and we have, of course, 28 plus states and many union territories. So and we build digital systems to integrate with each of the states' health infrastructure and so on, because data has to flow in quasi real time. And the second thing we did was Bluetooth tracing, where we use the phone's Bluetooth to track who all a person has been in contact with. And if one of your contacts later becomes positive, it then alerts you saying you were in contact with someone who later turned positive and you might be at risk, and gives you a degree of risk that you might be exposed to. And the third intervention we did was to take all of this data and create a database called Itihas, which integrated symptom data from Arogya Setu. So we used to capture location data along with each symptom response, along with the cell tower history of all the people who became positive. And we integrated and did a very simple exercise of sensor fusion, and using this technique we developed called syndromic surveillance. And the reason why this was tricky is that the symptoms that people are reporting are symptoms that can also be easily confused for flu and cold. So we created this heat map, which allows us to find outliers or hotspots, which will indicate whether there is a outbreak that is about to happen. And because symptoms predate, usually the symptoms pop up before the testing finishes and we get the test data, we were able to predict based on the slope of the symptoms and the actual symptoms themselves whether the infection outbreak is going to happen. So these were the 3 interventions, and we rolled it out in late March. 1st April, I think 2020 is when we first launched. And within 10 days, we had, or within 20 days, we reached about 100 million users. Currently, it has about 180 million users, which sounds like a large number, but it is, a little bit more than 10% of the country. And in a country with not a large number of smartphones, that is expected. So about the Bluetooth tracing efficacy, what we found is that we did a bunch of modeling based on information and models given to us by Professor Raghavan's team of epidemiologists, and integrating that model along with models of how Bluetooth operates. We worked with Qualcomm to model the Bluetooth itself. And when we integrated those two, we found that we were able to get good results. When the Bluetooth tracing model indicated that somebody is at high risk or urgent, there was a very high degree of probability that that person was positive, more than 30–40%. And this was in the backdrop of, at that time, the country was seeing a test positivity rate of around 5 to 8%. So this was a very high, success rate in terms of tracing and tracking. And even the medium and at-risk ones were better than the normal, wider sample, and proved effective. And this allowed us to then, feed better data. And of course, these patients who were caught early, they got better healthcare. But beyond that, it allowed us to provide better data to the ITIHAS system, which, can you go to the next slide, please? Yeah, so this integrated hotspot analysis, ITIHAS stands for history. So the history of where a patient has been before they were detected as infected, combined with where people are reporting symptoms, allowed us to create a hotspot map of the country. And the hotspots were down to 300-meter size, so size of cell towers. And we were able to predict with more than 90% accuracy where the hotspots are and where the infection is about to occur 7 to 14 days before the actual infection outbreak happens. And initially it was not clear whether this technique would work. So some states pioneered in using this data aggressively, states like Gujarat and then Punjab and Tamil Nadu. And the states that did showed extremely good efficacy in being able to turn the tide of the wave, they were able to reduce the peak of the wave substantially, and we were able to contain the infection. Can you go to, is there another slide or are we done? Yeah. And the final part is, if you're taking, very detailed information about a person's Bluetooth information, which is a Bluetooth information collects all the people's information around them, and you're also tracking a person's location. So this is sensitive private data. We used a 3-phase privacy stack. One was in policy and terms of service, where we said that this is very purpose specific. This data can only be used for COVID, not even healthcare, only COVID, and nothing else. And the second was data wipeout, where we said that if the data reaches the servers, it gets wiped out within 30 days if you're suspected of infection, and within 60 days if you're actually infected. The data gets wiped out and only anonymous data is retained. And the third one was to actually minimize the data that is sent to the servers. So the person's Bluetooth data primarily remains on this citizen's phone, and it's only downloaded if they are determined to be at risk and they consent, or if they are infected. If they are infected, there is a pre-consent taken when you download the app. At that point, it is downloaded because they may not be in a position to give consent. So that was the privacy stack we used. And of course, the databases were encrypted, and we had a separation of the user ID from the rest of the data and all the good practices that you're supposed to use. Go to the next one. So there are a few learnings. I will add one more learning beyond what is here. So the efficacy of this was very high. We were actually astonished that ITIHAS was able to give us 90% predictive capability, both in coverage and precision, in predicting where hotspots will occur. And we were also pleasantly surprised to see Bluetooth work as well as it did. Because Bluetooth, the problem with Bluetooth is, when you're outdoors, you are not as infectious, or you're not going to spread as much as you're indoors. And there might be, and Bluetooth itself is not an accurate tool. Bluetooth, strength is not an accurate predictor of distance. It's an approximate predictor of distance. There is a wide 1 sigma on that. And the other issue we had, of course, is that the country has only about 30% smartphones, growing. But good news was where the infection was high, which is urban areas, we had bigger smartphone penetration, so it helped. And the other interesting fact was that even though Bluetooth tracing required 30-40% downloads, the Itihas data required only 5% coverage to be effective, which was which was less than the coverage we had. So we were able to get detailed analysis of infection outbreaks even in rural India. The final question that I think is probably on top of everybody's mind is, why did it not work in the second wave? And I think there will be some analysis, maybe me and Paula and others will collaborate and figure that out later. But the primary, I think the single biggest factor is data quality. Because during stress times, the health workers on the ground who are responsible for onboarding user data, specifically the phone number of the person who got infected, could not always do it, because sometimes the person talking to them was not the patient, it was the patient's relative, or the patient was not giving their phone number, they were giving their relative's phone number. And we built OTP tools and all those things, but they were not able to be used on the ground for various reasons. And that turned out to be the Achilles heel. Initially, we had data quality of 70%, which was actually quite effective. But over time, the data quality, denigrated down to about 50% and 45%. And that's when the system starts fraying at the edges. And that has a cognitive effect on the population. So you occasionally see that you are being told you are at risk, but you're not, really turning positive and so on. And you see enough anecdotes. And without consistent messaging from people you trust, you stop believing that the system is working, which is okay, because the citizens doesn't need to do anything other than have the phone with them. But the problem is, in a world driven by social media, these rumors spread, and the health workers stop, paying attention to some of the digital tools. And of course, we had not pre-training. I mean, in hindsight, now going forward, we should do deeper training of using digital tools and so on. But this was the first large-scale digital effort on healthcare. So there were some lessons on the training front, and then some lessons on the data quality front, which are the takeaways on how to improve next. With that, I'll stop. Thank you.
We can restart now. Maybe we can take a couple of questions that are in the chat, and then we will move on before we move on to the Rwanda presentation. So one of the questions that came through into the chat is from Malikisi, who wants to know more around the core functionality and applicability of the SORMAS system in a day-to-day outbreak setting. And this was directed to Lois.
Okay, do you want me to answer that now?
Please do so, yeah.
All right, okay. Yes, thank you very much for the question. Yes, so as I mentioned, we have different modules that are embedded within SORMAS. We have the surveillance module, we have the lab module, and when I talk of surveillance module, in terms of we have this contact tracing module, the follow-up, and then we have the laboratory module. We have the case management, event-based, and then we have the monitoring and analysis modules. So in summary, some of this, what these modules do and some of the core functionalities include data collection and management in terms of due to the surveillance module that we have there. So we have the data collection in which all suspected cases are captured and then right from the lower level. And then we have the data management aspect of it, and that's where we have the monitoring and analysis module, where we can determine, okay, maybe the trend of the diseases and all that. And then we have the task coordination module, the task coordination functionality, such that when any user, makes any input into the system, the next level, the person who is responsible to take any action actually can see this task. And also there is a prompt whereby once an action has been taken, the person who is supposed to take any action or any responsibility, there is that prompt on, actually carrying out the function that is required from the person. And then we have the So these are basically some of the core functionalities that we have in SORMAS. Thank you.
So there is quite actually a wide variety of functionalities that are in there. Thanks for giving us more detail on that. And this leads us to, I think, quite a number of questions that came on immediately after, particularly with respect to the laboratory module, perhaps. And there are quite a number of questions coming through here, one from Obed, the other one from Aika, who want to know, is this SORMAS interfaced with the laboratory data management systems? Yeah, mostly laboratory information systems. How is it interfaced?
All right. Okay. Okay, thank you very much. One of the things I mentioned during the presentation is the fact that we want to make the system as automated as possible and reduce the need for manual entry. And so this is one of the ways by which we can overcome that, by ensuring that there is the interface between both SORMAS and the lab. And we have the integrating part, which that the system API that can integrate the different systems, not only the laboratory management system, but also the DHIS and all the other systems, because of this the interoperability that SORMAS system has. So there are actually efforts in place to ensure that you integrate both the SORMAS into the laboratory management system and all the other systems. One of such is this, we have the TB. And so at the moment, you're even interoperating with so many other systems apart from lab, but efforts are actually in place to integrate this.
Glad to know that.
But this can be done. This can be done with, both from our hand as well as from the lab end. So they all need to work together to ensure that this is done as seamlessly as possible.
Thanks, Louis. It's great to know that there is interoperability. And from experience with many of the systems, particularly that affect lab systems, you realize that when it comes to interfacing, it could be instruments, it could be information systems. There are usually some challenges when it comes to licensing. Is there any requirement for payments to be made for you to interface this SORMAS?
Okay, so for SORMAS, SORMAS is an open system, and that's why other countries can actually adapt it. As I mentioned, it's being used in Ghana and in Fiji and some other countries. So at the moment, SORMAS is an open source system. Then, so it now depends on what the other system you're interoperating with. So right from the end of maybe the agency or the system, whichever you want. So it depends on them. But for SORMAS is open source, and there is actually no need for cost in the use of SORMAS or interoperating with any system as necessary.
Thank you very much. Just before I move on to a question on India here, also talking about the open systems, what level of expertise is required, particularly for you to then manage that open systems? What sort of personnel are you looking at to be able to manage that at a country level? I'm looking at a country which wants to sort of adapt this.
Okay, so what we in NCDC, what we do is that we have our IT team. So when it asks you to do the technical aspect of SORMAS, they deal with the IT aspect of it. So we have them, so that's their role function, that's what they do. And whenever there is a need for interoperability with any system, so what is required is the need for expertise from the other, you also have a technical team from the other agency or the that may be interoperating with us. So they need that expertise. They need the core technical team, because coordination is quite different from the core technical aspect of it. So there is a need for that having a core technical team who would actually undo this particular aspect of it. And then there is the need for the server queue, which is where you host all the data that is coming in. So all this are actually required for this.
Thank you very much. Let me turn over to Lalitesh, and just like Prof. Vijay has mentioned, I think India is going through one of those difficult times with respect to the pandemic right now. And the question from Feisayo Jegede says, he or she says, what is the estimated literacy rate in India? I think he's asking, and indeed the area, indeed in the area where the IT tools were implemented. I think he or she wants to understand how it was it to use these digital tools, and what is the literacy rate with respect to the population.
That's a very important question, Anafi. So India's literacy rate is about 50 to 70% depending on the state. Some states are higher and some states are low. And India has, of course, many languages. So we implemented Arogya Setu at launch time in about 14 languages and expanded it to 18 languages. And the other thing we did from a design point of view, I mean, design was, I skipped about the design part, but we spent a lot of time making sure everything there is visual. And even if you are literate, there are different levels of literacy. So the amount of literacy you needed was very low. You needed to, be able to read a few words, and that would be enough. So you had to design it that way, otherwise, it would not be usable.
Thank you, Lalitesh. Also, moving on, and this one is coming from Oyeladun, who wants to know, I think this is, he or she is asking, with the ongoing COVID situation in the country, how are the data tools management systems coping with the burden in the system?
So the tools are okay. I mean, we had very rigorous load testing and security testing to make sure the tools don't break down under load. But what has been fraying at the edges is the human factors, especially the health workers on the ground who are collecting the data, specifically the patient data, because we have all the systems are tied together in the sense that the RT-PCR machines are directly feeding data into our system. So that has not been the issue. But when the patient data, specifically their phone number, which is the primary key we are using, that has not been accurate. And most of the gaps have been in that. And we are finding a similar, but far lesser of an issue with the vaccination. The vaccination system is also on the same platform. The vaccination system has been better because people have been paying far more attention, and vaccinations don't happen at the same pace as testing happens. And there the data integrity is quite high. And that is important, of course, because if you get one dose of vaccine and a few weeks later you need to get the second dose, you need to know which vaccine you got and so on. And it is place independent, which means that you can get one dose of vaccine in Bangalore and the second dose in Delhi, and the system allows for that.
Thank you again, Lalitesh. And this question, I think, is applicable to both the Nigerian experience as well as the Indian experience, and it's on. It's coming from Olayadun again, who is asking, what is there a plan to integrate SORMAS with other data tools like the HMIS tools, DHIS, and others?
Lois, do you want to take that?
All right, okay, thank you very much. Okay, so as I said, that SORMAS is interoperable with other systems, and one of such other systems is the DHIS and HMIS. So there are efforts also in place to ensure that we integrate all the systems, and I'm sure very soon we'll be able to, if we'll be able to tell a good story, that this has actually been done, as efforts are presently in place to do this.
Thank you very much. Paula, let me know if Mohammed is online now, then we can be able to move on to the Rwanda experience. In the meantime, we can continue.
I'm online.
Okay.
I'm already here.
Thank you, Mohammed. So let me just, there are quite a lot of interesting questions in the chat. To make sure that we get all the experiences, let me give an opportunity to Mohammed to give us the Rwanda experience, and then we can come back and address the remaining questions on India and in Nigeria, as well as those that to arise from the Rwandan presentation. Just to introduce Mohamed Semakula. Mohamed Semakula is a health scientific innovation analyst at the Rwanda Biomedical Center and oversees the use of IT tools and data science in the country's COVID-19 response. He is a statistician with extensive experience in qualitative data analysis and data management in the health sector, including spatial temporal modeling of diseases. So we are in Sapiens, colleagues. Mohamed, over to you.
Yeah, thank you very much for giving us this opportunity to just share with you about Rwanda's experience in terms of integrating data flow with multiple testing sites in both public and private sector, but also trying to minimize time required for data management, communication across the health system, but also those type of information, they are very helpful for the decision makers, especially in this era of COVID, where people, they need to get information as early as possible so that you can take the right decision. Every second counts as long as you don't have right information. So the epidemic can spread very fast. That is why Rwanda decided to have a full digitalized system for managing COVID-19. Next slide. So this is just an overview of the architecture of our data system. Remember that now we are having multiple challenges. One, you need to have the patient information. You need to get the community information. You need also to have those information synchronized for laboratory, but also for other interventions that you are having. That's how it's become a little bit complicated, and we come up with different systems, but all those systems are integrated so that we can have the real-time data for decision making, so that we can contain COVID or control the spread of COVID. So one of the system we have in the community, we are using we have a USSD just to screen the suspected, the potential suspected people, so who might be maybe COVID positive and so on. So that's how we come up with a USSD of 114, which anyone in the community can use it, and they will ask you some questions. And dealing with the algorithm behind that USSD, the decision will show you what you have to do. Either you have to go for testing, or you have to reach out to the nearest health sector and health facilities for testing, and so on, depending on the questions. The similar approach also, we came up with a WhatsApp platform that can do the same information. And at the end, those information can refer you for testing if depending on how you answered your question. That was one of solutions. We thought that, as you know, at the beginning of this outbreak, there were just rural testing kits across the country. Rwanda also was among those countries with difficulties of getting the testing kits. And then our approach was to test everyone that we suspect. And that's how we come up with this solution, so that at least we can minimize the number of people who really need to be tested by screening in the community. So if the algorithm refer you for testing, then you will be tested. That's when we build it. But another most important issue, as you know, most of our cases that we had were more on imported cases at the beginning. like the first 100 cases, COVID confirmed cases in Rwanda were imported cases. And therefore, we had to come up with a system to track on the point of entry or the port of entry. We called it a passenger locator form. So everyone before coming to Rwanda, you need to fill that form. There is some screening questions, but also you get codes that are linking you direct to our testing system. So the time you come here in country, we have some more information, whether you have been tested, whether you have been in a country with high risk of COVID and so on. But also, yeah, as you know, there is instruction that before coming, you have to get a negative test. At the same time, when you reach in the country, at the airport, you get tested at the airport immediately. So we are using that system, passenger locator form, which feed direct to our DHIS tool that we have, which is linked with the health facilities and the laboratory. This is when you fill the passenger locator form, you get immediately a unique code that you'll be using through all the interventions related to COVID testing and so on. You just use the unique code that you got from the passenger locator form. And that's unique code is the one also linked to laboratory information system. So, and your results will immediately be updated on the same code. So there is a portal for the results and so on. And then, for instance, if we found that you are positive, then there is another option. One option is that we are sending you to the either the home-based care, depending on your situation, or you will go to the treatment center. As you know, Rwanda has specialized treatment center for COVID. Not like every hospitals is treating. We have a center for COVID treatment, and this was decided just to reduce the risk of health workers in other settings, but also to avoid impact of COVID on other health programs. So then if you look, if you are going to home-based care, we have another system called WellTel, which is linked direct with your DHIS and laboratory system. Information will go direct in that system. And that system will enable those people who are following the positive case, they just get contact through SMS. They can also use a video call. But they are also, it's a dual system where you send an SMS to a patient, and the patient will also give you feedback immediately. And that's enabled us to follow very closely with people who are under home-based care to avoid the transmission within home, but also to avoid the deaths that can occur, because you are in contact with a patient 24/7, because we have a team that does contact tracing, and they're using that system, so they know everyone who is sick, and they are in touch every day. They know if someone is feeling good or is feeling bad, if you have a problem, so that they can decide if that person needs to be evacuated immediately. They can decide through that system, WellTel, that we are using. So, we have that team that's doing contact tracing is under an umbrella called the Command Post. Command Post was set at the beginning of Outbreak, which is a joint task force with the multiple people from different institutions, ministry, different ministries, including police, defense, all people who can support, so that we have a team that is there ready to support for COVID 24/7. Next, please. Then, so how our structure really look in terms of practical. This is just a diagram trying to show you. I'm starting with the one on the left with the yellow in the middle, it's the data science and IT solution. When we had our first cases here, we had to set up these different so-called unit. We had investigation unit. We have a contact tracing unit under command post. And we have also laboratory and the treatment centers. In other hand, we had rapid response team. That is a team that's in charge of evacuating people when, in case there is a problem, they will be coming to you and maybe take you to the treatment center. Or if there's any problem, those people, they are ready 24/7 to be deployed and react. And we have watchers. Those are people who in charge of getting information. We have a call center, but we have also the systems that give you information from the community level. And all those information are channeled through watchers. And we had also a communication that offers the accurate information. As you know, the COVID people, they have different informations. Then it was very important to have a communication team that's in charge of providing the accurate information in the community. And then there is also isolation center. Isolation center is just for people who are the suspect. If they suspect you before testing, you will be in an isolation center. Then if you test negative or positive, then they take you to the treatment, or they take you to a safe place where you cannot be able to transmit. Then there is also decision makers up waiting information from all those different unities so that they can take decision. And that's how we realized that we needed another team in the middle called the data science and the IT solution. So the data science provided the tool that each of those each of those teams can use. And whenever they put information, we can see those information synchronized at one server. And then we have a team of analysts, people who are working on analysis of all those information, and they can share the key indicators to the decision makers so that everyone can take a decision which is right on the real time. We came up with different dashboards depending on the purpose, and those were very useful in Rwanda containment because we could get real-time data from each angle. And all the COVID-related intervention were already digitalized, and we have a team of analysts. So it was really easier to control the COVID. Then on other hand, if you look, this is just at a lower level. When you go in the treatment center, what people are doing, our informations are entered maybe on the tablet or in a computer from the treatment center. Then the information are sent to the central server. So from central server, the information are connected direct to the National Reference Laboratory. And therefore, whenever there is a test, the treatment center, they can get automatically through the system and so on. But the same server can also provide the information on different dashboards for control room and for decision making. So you have the patient level information, the community level information, and you have the laboratory information in one platform. That makes also easier to use evidence in decision making. So everyone can have right of accessing what he needs. Like if you're patient monitoring chart, that will be most likely for the treatment center. So they have the full information from the same places. Next, please. And then another key important, I don't know other countries, how they managed to give feedback to someone who is tested. But at the beginning, it was very challenging to us. We are testing many people and everyone wants to get results. So the manual approach was not really working. That was definitely difficult. So we thought several approaches. One was like, okay, why don't you send just SMS of results and so on? But people will say, no, I need a proof that I was tested negative and so on. So we end up coming with this portal of results, which fetches information direct from laboratory and DHIS, and it's put your results on the portal. So a patient can use the same unique ID code and telephone number and get results. So if you are tested 20 times, you will see in your portal you have 20 times results and so on. You can look what was your results, and you can also print your certificate yourself. And that was very useful in terms of reducing the time and the burden to the health, to the laboratory of people requesting the proof of their testing and their results and so on. So everything was digitalized and it was self-service. You can get your certificate yourself on the portal. And once the results are available, the system trigger immediately the SMS, and you can see SMS that you are negative. If you want to get a certificate, just go on this particular portal and you put your unique ID code and telephone number, then you access your certificate. Next, please.
Mohammed, just sorry to cut in, a quick time check because we have about 12 minutes left before the session needs to wrap. So I know there's still exciting insights, but if you could just move through them quite quickly so we can still have some time for questions.
Yeah, I think this is the last slide.
There's just a couple more.
Yeah, so I think for this one, this is for the community approach. We came up with ASCOV, which is also helping in terms of screening, and it is already at community level. And we are trying also to bring in rapid testing at community level from the health facility. So we are working on that particular. Next, please. Those are some of the dashboards that we are using, and those are public dashboards. You can get access on those at Rwanda Biomedical Center. Next, please. So maybe to finalize, for the sake of time, I can summarize the Rwanda's experience in three main elements. We found that having integrated digital system to capture all COVID data in one place at the point of testing minimizes a lot the fragmentation and reduce also time spent on the health personnel on data management and transfers. Because this was a very very important, but also we found that it's very important to invest in long-term strategy to improve digital health system. To especially the health infrastructure. We are lucky that we had some basic infrastructure here in country which enabled the digital systems at least to be operational at this level, but there is much work that's needed to improve also the infrastructure. I think this is end of my presentation. Thank you for your kind attention.
Thank you very much, Mohammed, for sharing that exciting innovation as well. Key important practices coming through here. The use of dashboards as a best practice, which I'm glad we mentioned in the last M&E session as well. We're going back quickly because of time to some of the questions that remained. And I'm glad this presentation also answered some of them that had been posed earlier. I want to combine this question from Nomcebo Pumwayo, as well as the other question from Paula that was addressed, directed to Prof. Vijay, where both, I think, wanted to know, particularly with the uneven access. She says, Prof mentioned that the challenge of uneven access to digital technologies in the population. What efforts are being made to address this, and what are some of the approaches to address this divide? And Nomcebo also had the same question in terms of how do you ensure that those without smartphones are not missed?
Yeah, Professor Vijay Raghavan had to leave, so I will take that, Hanafi.
Okay.
So we addressed it by having a multimodal response. Every system we built, except for, of course, Bluetooth tracing, which does require a smartphone, we built with access on the phone and in physical. So for example, if you take the most recent intervention vaccines, we have the ability to register for vaccines on your smartphone. You can register for vaccination on a website. And of course, if you don't have access to either of them, you simply walk in. So there is a certain set aside where certain percentage of vaccines are set aside for walk-ins, and people can simply walk into a local, either a public health center or a private hospital and get vaccinated. But at the time of vaccination, there is a digital assisted mode where your information, including your social security number equivalent, which is Aadhaar, is onboarded into the system, so that when you come for the vaccine the next time, the correct vaccination is identified and given to you. So that is one example. And even in the case of Arogya Setu, we had both a IVR system, a WhatsApp. I mean, more than 500 million people in the country use WhatsApp channel, and a phone line in case you had symptoms and you needed immediate help.
Thank you very much. Moving on, I want to take this question from Clotet. It was in French, so this is a translation. So hopefully it captures what he or she was asking. And Clotet says, thank you to the presenters. We are seeing quite what looks like a sustainable solution to improve the COVID-19 responses. Now, in interest from many people who want to adopt this, how are users from other countries able to access these tools? And he or she specifically calls out, find what is it that we want to do for us to be able to develop such a tool? Is there any provision for expansion?
Anafi, is that related to a specific tool or just to tools in general?
I think he or she specifically mentioned Nigeria and India, what they presented.
Right. Okay, I mean, I think the representatives from both countries can speak to, potential for sharing across different countries, but these case studies, part of the motivation was from FINE's side, was to make people aware of what is being used and has been shown to be successful, although challenges of course persist, has been shown to be successful in different contexts. And at the end of this presentation, we'll also just share a slide that highlights some opportunities for other countries interested in building on that, as well as some contact details that people can reach out to find if they would like to get more information. Rikveda, would you like to add anything on that?
No, nothing further apart from just these repositories that are also available for just general understanding about what are the digital tools that are available. But yeah, I guess I would pass it back on to the country representatives from India and Nigeria.
All right, thank you. I think SORMAS is actually accessible via GitHub, and yes, that's why it's quite accessible there.
Yes, same with the Indian system. We have put it up in open source, and of course there will be some handholding required, and the country's digital community is always available to help.
Great, thank you. And there is a question that just came through. I think it's similar to the one that had been raised earlier, but that one was directed to India. And it's from Jacob, who wants to know what is the literacy rate, and because not everybody can access the results online. And
yeah, I think this question was answered before. The literacy rate is about 50 to 70%. So, and it's in a multilingual country, you have to release the app in multiple languages, but design the app so the person who is not literate can still use the app with a little bit of help. And the other thing that's very important, especially for COVID, which is a disease that affects the old, is you have to be very careful with design. So we had to actually use fonts which were large and images which were large, because the older people, many of the older, poorer people don't have eyeglasses and so on, so they have difficulty reading. So you have to design the entire system for, to make sure that differently abled people can use it.
Thank you, Lalite. Just quickly to clarify, we will be sharing these slides. I think I said a request for slides as well. An interesting question that is coming also just now is from Okung, who wants to know how different country experiences have been in handling this information using digital tools that we have developed. maybe Louis and then Lalitesh.
All right, thank you for the question. Yes, so in NCDC, we have our communications team and we also have our risk communication groups who debunk any misinformation that may be coming from the people. And so, so sometimes we send messages through our different platforms to debunk some of this misinformation.
Thanks. Lalitesh?
So I think this was a, especially when during the height of any, crisis, disinformation tends to spread a lot. And it's very hard to know what is, I mean, even now it is very hard to know what is science and what is not, because people are even publishing fake papers. So the only thing that we could do, I mean, we had to take 2 or 3 measures. One is make sure we publish official notes, which were peer reviewed by the various scientific advisories, various scientists across the country, and then published through official channels so people could know what they could rely on. And the other thing we did is, and of course, the second part is transparency of information. As much information you can make transparent, the better. And the final part is make the system as self-serve as possible so people can access information not just about themselves, but also information about their neighborhoods, without going through intermediate channels. So those were the 3 major interventions we had to do.
Thank you, Lalitesh. I know we are almost at the top of the hour. We tried to combine, I think, questions with a similar theme. Hopefully we have managed to address most of the questions. I want to hand back to the presenters just to give them a few moments to just give us some of their final parting words. Let me start with Louis. Lois.
Sorry, can you come again? I didn't get what you said.
Any last words, Lois?
All right, okay. Thank you very much. So to capital, what I want to say is that the use of SORMAS in the response to COVID-19 has really been instrumental in our response, especially with the quality of data that we're getting, which has informed some of our, our responses since the beginning of this pandemic. And so I would say that SORMAS has really, compared to, yes, we've tried in times past in the response, but SORMAS has really helped us this time around with response to COVID, and not only to COVID. You can imagine when you're having multiple outbreaks at the same time, that even with COVID, we're still responding to a number of outbreaks. Lassa is there, we have cerebrospinal meningitis, and then to cope with all these outbreaks at the same time. And if you look at the human resources that you require, it will really take a lot. So if not for this this digital system that we've been using, it has really helped us, both at the national as well as at the subnational level. And so this system has really been instrumental to us in our response. And thank you very much.
Thank you, Lois. Just quickly, Lalitesh, in 10 or so seconds.
Yeah, I think a digital system, I think, is critical for access. Without a strong digital system, we will not have uniform access especially during a crisis, for every last person. For example, we would not be able to deliver vaccines to 1.4 billion people without the digital system we are doing. But having said that, it's a terrible feeling, because no matter what you do, it feels like you're not done enough. And you kind of have to live with that. Maybe that is a motivation for us to keep improving these and make it wider access. And I think this also raises one more point to UN having declared in 2012 that internet is a fundamental right. I think we have to remember that, because without access to internet, many of these things won't work.
Thank you. Mohammed, quickly, in a few seconds.
Yeah, thank you very much for this type of platform. And I think it's very important to digitize the health system in terms of response. So it's make much sense that the country should invest much in infrastructure, the health information infrastructure, because without those infrastructure, most of the solutions that we're having in place will not be there. So thank you very much.
Thank you. Paula, quickly.
Thanks, Anafi and everyone. Just to point out what's on the slide, this webinar just really scratched the surface. We tried to present the key highlights, but the complete case study reports are on FINE's website, and some of the questions you might have could probably be answered within those. Please also feel free to reach out to us for any questions, and we'll be happy to respond, and if where possible as well, to connect you with opportunities if we're aware for operational support. Thank you all, and thanks a lot to ASLM for hosting us.
Thank you. And lastly, Rikweda.
Just wanted to echo and say thank you to ASLM, and also many thanks to our country representatives for taking time out to share their experiences. This has been very valuable. Thank you all.
Thank you very much. Without wasting more time, we have gone slightly beyond the allocated time. Just to say thank you for such a wonderful session. What I've presented right now on the screen is the code for those that want to go to the ASLM Academy and download the certificate. Till we meet again, thank you and goodbye.